much for having me, and it's an honor to be keynote speaker, and wonderful to be in this magnificent city of Paris. And I'll try to maybe make up a little bit of time and move through with some efficiency. She kind of already gave the introduction for, which was very kind. Appreciate that for what I do, and that reflects a little bit of biases, such as that I'm pretty involved in TMS, and so there's an inherent bias that we want it to work and work as well as we can. So these are the funding sources. There's no real relevant disclosures. There is a new transcranial magnetic stimulation journal that's about to start up that I'll be editor-in-chief for, and so I'll be getting a stipend from that, and otherwise no other sources of finance. So the background for brain stimulation, and I heard in the break, quite a bit of talk and questions about non-invasive brain stimulation, also invasive brain stimulation. This is something that's a really hot topic, and it's based on the idea that we have in the brain both an electrochemical organ. So everything really, everything in the brain, these chemical synaptic transmissions really serve, and some of these molecules like serotonin and dopamine, they serve to modulate the efficiency of the electrical propagation down the neuron. So this is really where we're interested in, and by using non-invasive brain stimulation, we can more directly communicate in the language of the brain. So this is Michael Faraday. With more time, I'd quiz everyone and have that. But he in 1831 invented electromagnetic, or not invented, but discovered electromagnetic induction, based out of London. This is I was just in London the week prior to this for the Clinical TMS Society meeting, and I'll show something from that, which is pretty cool. But essentially, what this law is that if you run a pulse through a coil, it generates a magnetic field. And then you turn it off, it goes away, and you turn it back on. And so it's only in a pulsed fashion that it's there. And so that's what hence the need for pulses, and you can detect an electrical current in response to that. And then on the flip side, if you move a magnet with its field through an electrical coil, you can generate, and you can think of this ohm meter really as neurons, because as you pulse these magnetic waves into the brain, you can pass very easily unimpeded through scalp and skull and modulate brain tissue or probe brain tissue, because the neurons as an electrochemical organ can detect these things. So this is actually the original coil. There was a special event on the first night where we were at the Royal Institution, and I'll show in a sec as well. Tony Barker, who invented TMS, gave this talk on the history of this, and this is where Michael Faraday gave many of his talks and worked actually in the basement for quite some time. And this is the actual coil that is there and on display, and so we all have the honor of getting our picture taken next to it. So very cool to see this history come alive. This is Tony giving this talk. Tony was so TMS was invented. First published in 1985. It had been worked on. It had been used for some time peripherally, and this was the first time that it was actually used to stimulate the brain, which obviously was quite a wow. You can see the motor evoked potential response to the stimulation that's recorded in the hand there. So this was really of high interest to neurologists, to neurophysiologists, people with peripheral nerve disease, and this is the University College of London, where John Rothwell works. He's a bit cut off here, but he is really one of the fathers and leaders of the field because of his early work in understanding how TMS modulates the brain through a lot of motor physiology work. And while he was working there in 1989, Mark George, who was just a recently graduated resident from the Medical University of South Carolina, and Mark George was my mentor. I actually trained in the same program that he did, a combined neurology psychiatry program. So he went to London to do fellowship in neurology, and happened to be passing through the elevator, and a guy's like, I just got magnetic waves through my head and it moved my finger. And he's like, where was that happening? Fourth floor. He's like, okay. And so he goes up there and asks, finds John Rothwell and asks if he can see what he's doing. And long story short, moved from the motor cortex to the dorsolateral prefrontal cortex. So after he was there, he went to the NIH, he observed this sort of classic finding that's not necessarily actually true in all cases. It's not just a matter of increased, decreased activity, but there was a pattern with, healthy participants having increased metabolic use in observed by PET scans, decreased with depression. So we thought, what if we gave this repetitively? And they had done a good amount of work identifying the dorsolateral prefrontal cortex as a site for depression. And so this was really how it began. And although this is a transdiagnostic talk, and that's my focus, depression is where it all started. So we start with that. And this is the first patient, essentially completely unknown. How many pulses do you give? How do you give them? How far spaced apart? So there was a lot of good guesses and a little bit of adapting to what came up. And this is, ultimately they led their depression rating scale, the Hamilton, eventually went down to remission levels. And so this was the first patient, and published in a case series of like 6 patients to kind of begin things. And then with that, they looked at these PET scans, both pre and post TMS. And as you can see, in the depressed patient, our TMS group increased, and in the recovered state, they were increased. So TMS changes, OCD was the next thing to be FDA approved in the United States. And then we had migraine, smoking cessation, and that's what we have to this point. And then there's a lot of things under investigation, which include a lot of neurologic indications. So stroke, PSP, Parkinson's, Alzheimer's, a few of the things mentioned today, hereditary ataxias, multiple sclerosis, which will be talked about later. So these are just a small sampling. I honestly think that in 20 years' time, we'll be talking about quite a broad range, equally distributed between different brain disorders. And I personally view neurology and psychiatry as kind of an arbitrary distinction. I think that they're all manifestations of things that are not happening correctly in the brain. So TMS, for me, is kind of the perfect space. I mentioned Tourette's because I like this transdiagnostic area. For just by way of background, I wasn't quite sure how many people would be familiar with TMS. So I wanted to include a little bit more as by way of background for that. That first study I showed you was in '95. This is in 2008, published in Biological Psychiatry. This is the study that led to FDA clearance in the United States and really started the ball rolling. And as you can see, and I'll point out especially the remission rates here, we're looking at like 14% remission rate with the active group. That's not that high. They wanted to keep sham as low as possible. They chose a very treatment-resistant group to try to reduce sham, because we see that this can be a very common confounder for our results. After they found this, though, showing that there was a difference, it was replicated, and almost the same numbers were found. And this one was an NIH-funded study, so there was no commercial involvement. And they also did a very good sham with this, and found essentially the same results as this. But it's not the real world results. But what we've seen so far today is a lot of real world results, right? Like what we actually care about with our patients. We try to leverage placebo, whether it's medicine, neurologic, psychiatric. We try to use all the things we can, from like warm, caring technicians and nurses and doctors, and anything that we can do to help folks get better. So this is going to highlight that. The data on the left is a recapturing of data from the STAR-D trial. This is a really classic depression study where certain medication regimens were used, and with each on the x-axis is the medication attempt trial, and on the y-axis is remission rates. And you can see after the first and second attempt, the chance of getting better is notably lower until we kind of get this theoretical, once they only went to 4. So beyond that is quite unlikely to respond, yet it represents a really large proportion of our patients, about 30%, which worldwide would equate to a prevalence of about 90 million. And so this is the first naturalistic study. They just followed people in the clinic and just did pre-post to see how they did. And you can see the response and remission rates were quite a bit better response is usually termed as 50% improvement in symptoms based on the scales, and remission is specific to each scale, and essentially reflects a lack of symptoms, so no longer depressed. And you can see, quite high, especially if you compare it to, what we're like, putting these straight across the board, pretty robust response for both of these. So this is when, in the US, insurance studies companies started to support this. But the take home point for this, for me, is that it hasn't changed a lot. So this is a newer, the reference on the top 2020 studies are from a large registry from a device company. And the rates of remission and response are pretty similar. And so it seems like we've kind of found where we're at, but I think that we can do better with this. This is based on, there has been no systematized approach to figuring out what's the best way to do this stimulation. A few things have been tried, but there's an infinite parameter space, so it's really impossible to test. And we don't really understand how it works. And that's the important thing. And once you understand a mechanism of something, then you can optimize it. You can fine tune it. Like if you have an engine, if you know how that works, then you can soup it up and, make it go really fast or strong or whatever. So I like the kite surfing analogy. Anyone kite surf here, kiteboard? I didn't think so. But nonetheless, by understanding the dynamics of the wind on the kite, device or kite manufacturers are able to, I don't know if you can see this, but there's a whole bunch of different, you can basically scale what you want to do, whether it's big air, free ride, surfing, etc. And these different shapes of kites, it's kind of a little bit subtle, but if you look closely, especially at the ends, they're designed differently, and so it captures the wind differently. Because we know how it all works, we can optimize and get exactly what we want. So my hope is that with TMS, we'll be able to do this one day. And I went with the big air kite, and it worked out well. So TMS produces changes on multiple levels, and this is an important point. Sometimes we talk about, the thing we of course care about is at this behavioral level. We talk a lot in the field about fMRI changes, EEG, looking at network changes, and then subserving those are neuronal changes, dendritic branching. And there's a lot of interactions between all of these, down to transcription and translation. And we know that with LTP studies, we need protein, we need transcription and so forth. But these really kind of hub around the synapse, and my PhD work was in synaptic plasticity, a lot of patch clamping, etc. And so I admit a bit of a bias here towards synaptic changes, because I see these, really as a key driver. Proteins are delivered to the synapses that are being stimulated with LTP, not just broadly and generally. And so we have specificity for what's delivered there, and it's the specific synapses that underlie the changes that we see in spines and network connectivity. And so I see the synapse as a very important part of this process. And as an overview, hopefully a review for most folks, this is synaptic plasticity in a nutshell. So in the center, you have this, baseline postsynaptic spine. You've got GluA2 receptors recycling. On the LTD side, when you give low frequency electrical stimulation, you have a cascade of events that leads to removal of AMPA receptors, and then it's less efficient in the synaptic transmission. On the flip side, high frequency stimulation leads to increased number of receptors and larger, more stable, mature spines. LTD does that through a low amount of calcium. LTP has a higher amount of calcium in acute bursts that come in, and this leads to increased numbers, specifically of the GluA1 type, and increased spine size. And I point these out specifically because these were looked at with magnetic stimulation in mouse hippocampal slices. And then if you block the NMDA receptor, it should block that effect. These are all classic characteristic features of LTP, long-term potentiation. And so our question really is, does TMS, specifically, we have low frequency protocols like 1 Hertz and continuous theta burst. We think that these work in an LTD-like manner, but we don't know. And it's really the same with high frequency. Does 10 Hertz or ITBS, do these capture the same thing that we have there? These are unknown. These have been undetermined, particularly in humans. So I'll show Andres Vlachos's work in Freiburg, and actually was just prior to London, was visiting Andreas' lab in Freiburg. He showed that in mouse hippocampal slices, these are just spontaneous events called miniature excitatory postsynaptic currents. The group that's post PMS, post magnetic stimulation, had larger and more frequent events, indicating more AMPA receptors per synapse and more connected synapses. They looked at spine sizes over time, and you can see by the 3 hours, it had grown and increased. And these are all characteristic of LTP. And looking directly at comparing the excitatory currents, you can see in the red the much larger peak here, which also again indicates more AMPA receptors in the synapse. And this is a direct observation of that. So this shows the functional insertion, the electrophysiology, and then the imaging shows that there's actually increased GLUA1, and that's the type of receptor that's delivered with LTP. So our question is, does animal work correlate with humans? This is, we've Alzheimer's was pointed out, and I'm sure if there was more time, he could have talked about how we've had amazing cures for Alzheimer's with mice, but it hasn't translated to humans. So does this translate? Our model for testing this is we give TMS over the motor cortex, and it allows us to easily observe motor evoked potentials. And so a lot of work's been done by John Rothwell, who I mentioned, and we feel confident we can point to cortical excitability as the reason for changes when we give TMS to this. So we basically get baseline with an MEP. We give a protocol, a plasticity protocol that we think will modulate the strength of this, and then we look at the post. And we see, okay, did this increase the size of our MEP? This is essentially our index of plasticity. And then we do all this importantly with receptor modulation on board. So we give a drug, and by having the drug on board both pre and post, we can see how did, for example, blocking the NMDA receptor, how did that affect TMS to do what it does? It doesn't need the NMDA receptor activity to carry out its function. So that's what we did here. Well, I actually just had this here. So if we increase NMDA receptor activity, we should see an increase in the peak. If we block it, we should see a decrease in the peak. So I'm going to start with the blocking side of things, because that's what was done first. There was a couple of paired-associative stimulation protocols. These are something that are not used clinically, but we use them to induce LTP-like events. And with intermittent theta burst, this is used clinically now. And this was early work by John Rothwell's group, and memantine is an NMDA receptor blocker. And they essentially found that with blocking NMDA receptors, you lose that enhancing or potentiating effect. So NMDA receptor activity based on the PAS studies, and especially this intermittent theta burst study, we see that it is necessary, but is it sufficient? So if you want to be a neurologist, you've got to go to grade school, college, medical school, got to take your boards, and you've got to go to residency, right? Like all these things are necessary. They're required as a part of the process. Necessary, but only the residency is sufficient. Only completing the residency do you become a neurologist, at least, and there's derivations of this, of course, in different countries, but this is United States model. So we wanted to test whether we could increase this, and this is essentially what we found. So we use D-cycloserine at low doses, acts as a agonist of the NMDA receptor, and so we see in the gray placebo group, we get the normal rTMS-induced plasticity, and when we add D-cycloserine, and this was done in a crossover study, so subjects had one and then a 1-week washout and then got the other one, so we're comparing within subjects. And with D-cycloserine, they had a more LTP specific type of enhancement. So NMDA receptor activation is sufficient. And then we wanted to see, okay, what if we did the same thing, but then like we do in animal experiments, block this activity. So we'll add something in and then we'll knock it down and see if the effect is specific. So this was in a separate group of people with a different 10 Hertz protocol, but it's similar. I'll point out the nuance in a sec, but a little bit different. And so we again found that D-cycloserine increased the plasticity, and then adding the blocker decreased again. So dextromethorphan is an NMDA receptor antagonist. we're able to knock down that effect in human motor cortex. So this was able to affect that. And then we did this protocol as the previous one I showed was only 300 pulses, was used as a motor protocol previously. We wanted to replicate and see if we could come up with the same thing. This is actually the first time that the conventional clinical protocol was used, because we wanted to see how is TMS working to know how we can improve it. And so what we're looking at before is basically just, does it increase, does it decrease? But it doesn't say as much about the underlying etiology, the cause of the change. So we use paired pulse because this gives us some insight into GABAergic versus glutamatergic contributions. The idea with this is you take a baseline pulse. This is just a typical single pulse. With the ICI, which is intracortical inhibition, you give a pre-pulse that's below threshold, so it's not enough to actually cause the movement, and you do it right before less than 5 milliseconds, and you get an inhibition of the response. And then for the ICF, for the facilitation protocol, if you spread that out, you get an increase in this. So that's what we did with this. And on the this bar graph or the line graph here, this is placebo. We did pre and then post RTMS. And then we did the same thing here with D-cycloserine. And so what we found here was normal intracortical facilitation. It's a pretty typical slope when you're comparing the baseline with the post. After getting the 10 hertz RTMS with placebo, we see larger. You can see the slope shows a increased facilitation. And we also, in the pre-TMS condition, saw increased ICF, which I would think would be related to having this NMDA agonist on board. Interestingly, though, our initial thought was after the 10 hertz with D-cycloserine, we'll see a further increase, but obviously you can see we didn't. We saw that it was sort of this flattening effect, kind of a ceiling effect, which we refer to as occlusion in the animal literature. And this is from a seminal study out of Brown University, where you can see that they give, they train mice in this learning and memory protocol, and then you can see they come down here to this normal, they basically don't have any potentiation, but in the untrained hemisphere, where they didn't have previous LTP, they were able to increase this. So they showed in a couple different ways that if you give LTP and then you do LTP again, it occludes it. You've saturated it. So that's what we think is happening here. And this is, this needs animal work to really demonstrate and show that this is what's happening. So this is, it's still a bit hand wavy and speculative that that's what's going on. Similarly, with the intracortical inhibition, we get the normal sickies. This is short intracortical inhibition. We get normal sickie after. We don't think it would have as much of an effect, the 10 hertz, if we think it's through GABA. And then there's a decreased amount of sickie here. You can see the line is flattened out a bit. And then this again was very confusing. Like after TMS and D-cycloserine, there's more inhibition. It seemed opposite to what we'd think. But again, looking to the animal literature, it seems like there may be some, you induce homeostatic depression after you have LTP. It's a way of scaling the synapses and make it so that it's in a modifiable range. And so it may be, speculatively speaking, until we can test this in animals, may be that there was a decrease already in ACT, and then adding the Sickie protocol on top of it further decreased that. And then this shows here both at the synapse, the number of receptor level, as well as the electrophysiology recordings, which reflect the receptor levels, how increased activity leads to decreased receptors and responses, and vice versa. And then, this actually has been demonstrated before in TMS in humans. When you give I'm going to use loosely inhibitory protocol before an excitatory protocol, it increases it. So that's the red. However, if you give an excitatory protocol, ITBS, before another excitatory protocol, ITBS, you occlude that potentiation. So we think this is reflecting some interesting things that are going on in the synapse, and we see the same thing on the inhibition side. And we wanted to essentially look at this same thing in our population that we were doing these experiments with. And so caffeine, we know, has an excitatory effect on the brain. People that are chronic caffeine users have this chronic excitation, and in the same group that we showed the results for previously, we did a post hoc analysis, just sort of a subgroup to see, okay, how do these people do? And we saw that there was this pattern where the non-caffeine users in red seem to have higher excitability than the caffeine users. And at a average group level, we saw a difference between these folks. And so it may be that chronic excitation reduces the facilitation, the ability to facilitate or potentiate. On the flip side, looking at a more classic Hebbian plasticity, named after Donald Hebb, we wondered if use of this over time, the saying that neurons that fire together wire together, right? Everyone hopefully has heard that, coined by Carl Schatz. But attributed to Donald Hebb because of what his seminal work was. So we wondered, okay, people that have used their motor cortex a lot for musical instrument or athletic functions, do they have more plasticity and a greater ability to increase this? And again, the red was the musicians and athletes. Sorry, something happened with the label. It's something happened with it down here, but the red is the musicians and athletes and the blue is the non-musicians. And you can see that there was this trend towards this, we could observe a directionality increase. And again, we saw that the musician and athlete group, when they had the D-cycloserine, had a much larger facilitation or potentiation. So these demonstrate some interesting findings about how TMS might be working in the brain. This was essentially a replication, so a new data set that we had where we added the dextromethorphan group, and we saw that it had a sort of a blocking effect on this D-cycloserine. I won't go into that in too much detail because of time, but so we've been focusing on glutamatergic NMDA receptor activity, but nothing's in isolation. So what about the GABA receptor? And then again, I'm turning to Andre's foundational work with animals. They found that giving the same protocol actually decreases GABA receptors, which is essentially cutting the brake. So that's how you get the excitation. So this is an alternative hypothesis to what we've been talking about. So in addition to the decreased functional insertion of these receptors, you actually have decreased number of receptors on confocal and decreased Geffen clustering scaffold proteins. So the whole complex is decreased after TMS. So we wanted to test this more directly, and to do that, we, in the same subjects, wanted to directly compare data that I already shown, D-cycloserine to dextromethorphan, but we also wanted to add lorazepam as a GABA agonist. And so the idea is, if you have lorazepam exerting its inhibitory effects before TMS, and then you give TMS, if it reduces the number of receptors, afterwards, it should have cut the brake a little bit, and you shouldn't have as much effect from the lorazepam, so it should increase the overall excitability. That was our rationale and our thinking for this. So an increase would suggest that there's an increase after would suggest that there's GABA. And we didn't see that. We saw that GABA in both a 10 hertz group and an intermittent theta burst group that we studied showed decreased post RTMS. These are normalized to baseline. So roughly speaking, it doesn't seem that GABA had as much of an effect as the NMDA receptor. So then, our kind of ultimate question is, does this actually have clinical relevance? Can we leverage this? Can we utilize this to improve what we're doing? That's the whole rationale behind it. And just like the previous talk, we want to understand these things so that we can ultimately improve what we're doing. And so this was really critical work by Alex McGurr. And I think this study, to my knowledge, and to a number of other people that I've talked about this, nobody has seen an effect like this in psychiatry, this sort of magnitude of effect. So this is the dark bar is intermittent theta burst with placebo. So this is essentially standard of care treatment. And so this is a comparison between that. And the light colored bars show that the remission and the response rates at 2 weeks and at 4 weeks out. Importantly, ITBS was given for 4 weeks, but the D-cycloserine was only given for 2 weeks to avoid the homeostatic depression effects that can come that I was describing. So this was an enormous effect, but it gets even better in some open label data just to do some weight-based dosing and to see how 4 weeks of D-cycloserine does. You can see these are the responses. This is unpublished, but with his permission to share, these response and remission rates are enormous. There's really nothing like it that's been done so far. So this is very promising. It still needs replication in a larger sample size, and one of our collaborators in Australia is working on that now, as well as Alex and I. And one thing that's a very interesting observation from this is these are, this is the serum level. Notice these are all remitters. They don't have depression anymore. So essentially, what any of us with normal mood would be at. And so it was those that had the lower levels that didn't remit, those that had the higher levels did. And then importantly for this purpose, he also has some preliminary data with OCD to see if this is transdiagnostic, and it has the same appearance as the depression. So I'm really excited about trying this with substance use, with Alzheimer's, with stroke recovery. There's a number of collaborations that are being set up in the mix right now. And I do think that this will be a game changer for what I call brain medicine, which is neurology and psychiatry together. So in summary, we looked at high frequency TMS stimulation. We saw increased numbers of what we think reflect AMPA receptors, spine size, etc. We validated that this has a clinical effect and relevance. And so that's essentially the talk. And then I just want to put a plug in for the Clinical TMS Society in Elsevier. This is the journal that's being published, TMS, and for anyone that's doing TMS research, we'll be starting to accept articles in July or August. And then this is all this work is with a huge thanks. This wasn't me doing the actual work, but our lab, who does amazing work, as well as the funding sources, the philanthropic support, and collaborators that have really made all this happen. So thank you for your time.